Uh, Thank you, IAP Latur. Actually, I belong to Latur as it is my native place. Today, I'll be discussing in short about bedwetting. Bedwetting, what we generally see, is a benign disease. Most of it does recover completely, and but it is very annoying for kid and parents both. So before we discuss about exact bedwetting, the common we need to understand what is nocturnal enuresis. What I mean by nocturnal enuresis is generally what we anticipate in our practice, relatively benign disease. And what is not actually nocturnal enuresis, that means it is beyond normal problem. When shall we treat? So that means not every disease needs treatment. Same way, what are the treatment options available? Which therapy is better amongst that? And when child needs reference? We'll start with cases. A 7-year boy presented with bedwetting, urine stream is good, received imipramine. I think that is most time-tested, used medicine from most of us, commonly known as dapsonil, but there was no improvement. When we assessed in detail, there was increased urinary frequency, there is a history of urgency with intermittent incontinence, and also constipation. So before starting imipramine or any other medicine, we need to understand what problem we are dealing with. Is it a dog which can be tamed, or are we fighting with some bigger animal which requires very aggressive and different approach? So these symptoms can be seen even urological problems like posterior rectal wall, neurogenic bladder, lot of bowel bladder dysfunctions, and even stenotic lesions. So first we shall be sure that we are dealing with nocturnal enuresis before starting any medicines or before doing any counseling. A little bit about imipramine before we shift to main topic. Imipramine relatively saved up when used in proper concentration, but 5% of children do have some side effects, maybe in the form of neurological or cardiac issues. And that's why it is recommended that before starting imipramine, cardiac evaluation is mandatory in detail. But the dose generally we use hardly ever cause problem. Another case, a 4-year boy presented with bedwetting, no lower urinary tract symptoms. What are those will come afterwards. But there was a history of polydipsia. So again, in this case, it is not primary monosymptomatic nocturnal enuresis. It was a polyuria polydipsia complex which is presenting as nocturnal enuresis. So again, this is entirely different group, requires thorough evaluation, and there are no use of any medicines what we use in nocturnal enuresis. So what I mean to say that if parents are coming with complaint of bedwetting in the night, we are not justified in starting dapsonil, imipramine or any other agent blindly before evaluating child in detail, trying to reach the cause root. So few terminologies. Enuresis are these episodes of incontinence during sleep in a children more than 5 years of age. These are International Continence Society for Children guidelines. So less than 5 years, we generally don't label it as an enuresis. What is monosymptomatic? That means there are no other lower urinary tract symptoms and neither there are bowel symptoms. So it should have exclusive and only complaint as bedwetting in the night time, no daytime symptoms. It can be divided into primary and secondary. Secondary means enuresis develops after dry period of 6 months. So in between for 6 months, child never had bedwetting and again has started wetting the bed. What is the most common cause you can think of in secondary enuresis? Any guess? Sorry? Most of the time there are no identifiable causes. So initially, whenever child used to present as secondary enuresis, yes, definitely common causes we are going to rule out, like urinary tract infection, which remains one of the common cause, or maybe investigate accordingly. But otherwise, most of the time, if it is a monosymptomatic secondary enuresis, still it is harmless condition and can be managed very well. Non-monosymptomatic means along with enuresis, that is bedwetting in the night, nocturnal enuresis, there are either some daytime symptoms, some bowel problems, or some neurological issue. And non-monosymptomatic enuresis definitely requires thorough assessment and probably a referral before starting any medicines. So non-monosymptomatic enuresis, we are not going into detail because that requires detailed evaluation. Now, what are the symptoms which can help us pointing towards non-monosymptomatic enuresis? Urinary frequency, normal frequency is between 4 to 7 times in a day. If it is more than 8 times or less than 3 times, it is always abnormal. If along with nocturnal enuresis, child has daytime incontinence. What I mean by daytime is not afternoon nap. It is when child is awake. So if child wets bed during afternoon nap, it is still included in nocturnal enuresis. If child has urgency, hesitancy, straining, poor stream, holding manure, incomplete emptying, child gets feeling that despite voiding, bladder is not empty completely, post-micturition dribbling, and another important is incontinence. So any of these are present, we are not justified in starting medicines immediately for any. So these all kids require referral. Now, what is the natural history of bladder? At birth, it is generally a spinal reflex. It is uncontrolled but efficient. Efficient means, as sir pointed out in previous talks, bladder should empty completely. So it is uncontrolled but efficient. We expect control during daytime by 4 years of age. So if it persists beyond 4 years, we are not going to wait for 5 years to define as a nocturnal enuresis. If child waits during daytime after 4 years, it is abnormal and require urological evaluation. And nighttime control is expected by 5 years. But very good thing about nocturnal enuresis, most of it resolve by age. But if we assess a first standard child, so in that first standard class, almost 10% will be having complaint of bedwetting, but maybe because of social taboo or parents are not very considering it significant, it goes unnoticed. But amongst these 10%, 15% resolve every year, and after 15 years, we see hardly 1 to 2% patient still wetting in the bed. So this is the chart. Even if he waits daily or occasionally, still most of them do recover well. Now, pathogenesis has been discussed variedly. The most common thought, what we used to assume as a deep sleeper, but the commonest cause is maturational delay. That means bladder and brain are still not matured enough to understand that he needs to get up and void. So that is the most common cause, and that's why we expect good recovery in monosymptomatic nocturnal enuresis, because it is getting matured little late, that's all. Genetic factor, very important. If one of the parents had nocturnal enuresis, then there is 50% chance, and if both had, then it's 75% chance. But probably this is the least history we get from parents. Everybody is in denial mode, but most of the studies have shown there is a high risk. Then nocturnal polyuria, excessive or disturbed sleep, small bladder capacity. Now, small bladder capacity is not anatomically small, it is functionally small bladder. So here, role of oxybutynin is important. There are associations, ADHD, autism, intellectual disability, and it can even lead to low self-esteem and adjustment problems. Now, the last case, a 8-year girl presented with bedwetting, also waits during afternoon nap. So I have already made clear that this does not add anything further than nocturnal enuresis. And again emphasizing, before assessing, ask for lower urinary tract symptoms, assess for polyuria, polydipsia, and look for detailed history for constipation. If nothing is there, then what we need to evaluate, most and foremost important, that will decide our outcome, is how motivated family and child is. Suppose both of them are not motivated and just come as a flying visit, no point in starting any therapy, because failure rate is very high. Suppose parents are motivated, child is still not motivated, we may need to give some time for child before we start on therapy, because even if we start desmopressin, imipramine or any other therapy, failure rate goes almost 70 to 80%. So initial priming may be just making child understand this is not normal. So motivation is very important for both family and child, because this fight is not for 4 or 5 days, it will go on for 3 to 6 months. And again, what are their main concern? Waiting only during outing or when child is at home. If their target is only control bedwetting during outstation visit, easy to manage. But if you want long-term control, again requires a long struggle. And have any intervention has been tried before? But again, before starting treatment for nocturnal enuresis, this needs to be addressed. Even any assessment of bladder, urine diary, everything can wait unless constipation is controlled. Because most of the studies have proven just controlling constipation can help in controlling nocturnal enuresis. So Upendra sir in the morning said very well emptied bowel is happiest reason for bladder. Physically, ask for any spinal dysraphism and neurological evaluation. Other investigations can wait. I don't think UTI lasts for years together to manifest as a nocturnal enuresis. If child has nocturnal enuresis, it is unlikely to be urine infection. And again, sonography is not at all mandatory unless child has some bladder symptoms. Now, when shall we start treatment? General dictum, we wait till 6 years, but each 6 year cutoff. No, if child is more than 5 years and child himself is very irritated because of these symptoms, we can start treatment then and there, provided parents are also equally motivated. And if that motivation is still not there, puberty, now it is time for us to educate them that this needs to be addressed. So otherwise, age after 5 years is not a limit. Before we start any therapy, we need to counsel. It is very common disease. 10% of 7-year child will have this. And most of these cases do improve, yes, but therapy will make it improve fast and it will not cause problem associated with behavior of the child. It does not indicate any kidney disease, and neither kid nor parents are at fault. Initial management is always on education and motivation. No drugs in initial management. So education, good thing is calendar. Parent and kid both needs to be educated that every 7 to 10 days they need to assess calendar, how much is the frequency, so that it will give a sort of motivation for both of them if frequency improves. He should be educated that void at least 4 to 7 times in the day, and one void before bed is very important. Evening, avoid sugar and caffeine. Caffeine is a sort of bladder irritant, so all cola containing drink and coffee should be avoided. And high sugar causes osmotic diuresis, so that also needs to be avoided. Fluid restriction, followed formula is 40, 40 and 20. That means till 12 o'clock 40% of the fluid, till 5 o'clock remaining 40, and after 5 fluid should be restricted. And avoid fluid, water, cold drink, coffee, milk, anything after meal, after dinner I mean. So that will help in improving nighttime frequency. Avoid diaper, because child is in comfort zone when he is using diaper. He does not understand importance of avoidance of bedwetting. Then motivation is always stepwise. We can't expect a baby to directly run or stand. Always he will start with crawl, then stand, and then start walking. So don't ask kid immediately that from here we are going to count how many times you wet bed. Initial should be ask him that he should void 4 to 7 times. Then next step will be ask him to void before bed. Then next time give 1 day target that today we'll hope that you won't void, and then shift to long-term target. So motivation also always needs to be stepwise, and punishments are counterproductive. Every study has proven that if you take away the benefit he got from not wetting bed, on the next day if he wet, he get punished, it will be always counterproductive. So there is no negative reinforcement, no role of negative reinforcement in treatment of bedwetting. Now comes active therapy. Now being doctor, always we want to give some medicine or some or other intervention. No improvement after 3 to 6 months of initial trial, then start on medical or alarm therapy. So initial motivation is very important before starting any other therapy. Now on one side we have multiple medications, pills, and on other side we have enuresis alarm. Enuresis alarm, the electrode is placed in the undergarment of kid, and the moment child voids first drop of urine, it will start ringing. And medicines we have now, desmopressin is on the top as an effective management of nocturnal enuresis, and tricyclic antidepressants are lower down. So which is better, enuresis alarm or desmopressin? Most of the studies have proven beyond doubt enuresis alarm is better, has long-term better outcome. But if we want short-term improvement, desmopressin. If caregivers are very much annoyed, they always scold the child, sometimes get a physical abuse, desmopressin is better because they don't have patience for alarm therapy. They want shorter commitment, then desmopressin is better. But for long-term better result, always alarm therapy is more high given. In OPD, if parent scolds child because of his bedwetting, even assess angle of physical abuse. Because parents are in denial that this is a normal process and they always try to scold the child. So if angry parents think of physical abuse also. Any of this if we start, whether positive enuresis or desmopressin, at least 3 months we shall continue. After 3 months, we can give a gap of 7 days for desmopressin to assess whether it needs to be continued further. For alarm, reassess at the end of 3 months. If there is a partial improvement, continue same therapy. But if there is a no improvement, reassess again about urine diary, urine chart. Think of adding another medicines. But before adding another medicine, revisit the child again. So, if no improvement, take a opinion. Use of combination therapy, that means, just 2 minutes, use of combination therapy along with alarm, we can add desmopressin. If we are with desmopressin not improving, consider a next agent, that is anticholinergic. Tricyclic antidepressant is used as a last drug. It is like a milder antibiotic which covers everything. It improves bladder capacity, it decreases sleep, and at the same time it has some role on vasopressin also. But we can't treat with a mild antibiotic for every infection. So it needs to be focused, and it is also associated with side effects. So when we have a better option, TCA, tricyclic antidepressants comes very lower down. And after that, few other drugs have been tried, but had shown some improvement, has not shown very long-term outcome. So to summarize, detailed history and urine chart is important before starting on any medicines. Monosymptomatic enuresis, most of them does improve with time. Motivation of the family and child is the most important factor what will decide our outcome in the therapy. First step is always education and motivation, and active therapy, the most efficacious is alarm and desmopressin. So if child is terrified, irrespective of age, treat nocturnal enuresis. Thank you.